My name is Rylee Fritsch, and I attend St. Mary of the Woods College Bachelorette of Science in Nursing program. Today, I'll be discussing the Visiting Nurses Association Home Care and Hospice Diabetes Mellitus Lesson Plan for Home Health Nurses. This presentation is targeted towards staff nurses, RN, and LPNs. I'm going to be using the social learning theory today to better help you understand these teachings. Some of our objectives include recognizing the prevalence of diabetes mellitus, differentiating between type 1 and type 2, recognizing the complications such as hypo and hyperglycemia, describing the role of nutrition and exercise management in diabetes mellitus, as well as describing the treatment of nursing care of a patient with diabetes mellitus from a home health nurse's perspective. Also, discussing education of glucose monitoring, insulin administration, and diabetes complications. The prevalence of diabetes is pretty large. Internationally, about 483 million adults aged 20 to 79 live with diabetes. In the state of Indiana, 738,000 adults and children have diabetes, and 1.7 million of those have prediabetes. So overall, diabetes is a pretty prevalent disease, not only statewide in Indiana, but also internationally. At a glance, there are some differences between type 1 and type 2 diabetes mellitus. Type 1, there's an autoimmune destruction of beta cells. Usually, it's juvenile in onset, it's insulin dependent, and only about 5% of all diabetes mellitus patients have type 1. The main thing to understand here is that there's a genetic susceptibility with a triggering event in type 1. In type 2, it is a progressive condition caused by insulin resistance, decreased production of insulin, often occurs later in life, and usually about 95% of all diabetes mellitus patients have type 2. There are some signs and symptoms differences as well. So something to note is that pretty much the signs and symptoms between type 1 and type 2 are about the same. The difference is that type 1 has a sudden weight loss, and also there are different complications. So type 1 has sudden weight loss, fatigue, weakness, polydipsia, polyuria, polyphagia, paresthesis, visual changes, slow healing lesions, and recurrent infections. The complication of type 1 is diabetic ketoacidosis. Type 2, the exact same signs and symptoms, but it does not include sudden weight loss. The complication of type 2 is hyperglycemic hyperosmolar syndrome. Further complications of diabetes mellitus include hypoglycemia. Hypoglycemia is a very large thing to focus on when thinking about diabetes mellitus. In the home, for home health nurses, this is something that can be very dangerous, especially if a patient lives alone. So it's important to understand the signs and symptoms, the causes, and what we should do in the event. So hypoglycemia is essentially blood glucose less than 70 milligrams per deciliter. There are 3 stages of the signs and symptoms. There's mild, moderate, and severe. Mild symptoms include being anxious, sweating, having palpitations, tremors, hunger, or being irritable. Moderate signs and symptoms of hypoglycemia include headache, confusion, drowsy, double vision, slurred speech, and a lack of coordination. Severe signs and symptoms of hypoglycemia include difficulty arousing, seizures, and loss of consciousness. Some of the causes of hypoglycemia and some of our patients that we will see at home are drinking alcohol or chronic alcoholism, not eating, taking too much insulin, exercising excessively, or taking too high of a dose of a diabetic medication. As a home health nurse, what should we do if this situation arises? Well, we should give 15 to 20 grams of fast-acting carbs. The ones that I recommend are about 4 to 6 ounces of orange juice, a lozenge such as Jolly Rancher, something very high in sugar, not anything like a long-acting carb like a candy bar, like a Twix. You're going to want something that's immediately sugar to help spike that glucose back up. Another complication includes hyperglycemia. This is another dangerous one. This is one that can cause diabetic ketoacidosis in type 1 or hyperglycemic hyperosmolar syndrome in type 2. Hyperglycemia is defined as blood glucose of more than 250 milligrams per deciliter. There are some signs and symptoms, some causes, and what we should do if this happens that we should really be paying attention to. So the signs and symptoms are if they have hot or dry skin, if they have acetone or fruity breath, if they have polyuria, polydipsia, weakness, blurred vision, headache, nausea, vomiting, or abdominal cramps. Some of the causes could include illness, stress, overeating, taking corticosteroids, or taking a too low of a dose of a diabetic medication. So, as a home health nurse, if this happens to you out in the field, what should we do? Administer insulin or other prescribed diabetic medications. Encourage oral fluids. Recheck the blood sugar after the insulin or medication is given. And check your urine ketones. Again, remember, diabetic ketoacidosis can happen here. So that's why we're going to be looking at our urine ketones, because ketones in the urine signifies an acidotic state. So it's important to note if there are ketones in the urine. And if there are ketones in the urine, you should notify the healthcare provider. Treatment overview. So in terms of goals of management as a home health nurse, we should be looking at reducing symptoms, promoting well-being, preventing acute complications of hyperglycemia as well as hypoglycemia, preventing the delay and onset of progression of long-term complications, which we're going to be talking about long-term complications later on. An education point that we should be not only understanding for ourselves if we're going to be checking blood glucose in the home for the patient, but if a patient is a first-time diagnosis, or if you're teaching a caregiver, or or what have, if you need to teach about self-monitoring of blood glucose, these are the things that we should be teaching. So first and foremost, check the expiration date of test strips. Make sure the patient or yourself, depending on if this is what you're doing or if you're educating the patient, wash the hands in warm water and make sure your fingers are dry. Alternate finger pads. So that's a big one, because later on we'll talk about this, but healing is impaired in diabetic mellitus patients. So if our healing is impaired, we don't want to be sticking in the same exact spot every single time. So it's good to alternate fingers, and also alternate from maybe your right hand to your left hand, especially if they're checking their sugars more often. Because if a patient is sick, they should be checking their sugar more often, 2 to 3 hours in a day, like every 2 to 3 hours in a day if they're sick. So they might be sticking a lot of fingers, or a caregiver might, or you might. It just kind of depends on the situation. So again, check the expiration date, wash hands with warm water and dry the fingers. Alternate finger pads. Place the lancet on the lateral aspect of the finger. Record the results. And this should be checked whenever hypo or hyperglycemia is suspected. It should also be checked more often when sick or very stressed. And it should be checked before and after exercise. In terms of diet education, diet is a huge one, especially in type 2 or pre-diabetes, because we can prevent these things from happening if we have good diet and exercise routines. So in terms of diet education, you should teach that the patient should have a day-to-day consistency in timing and amount of food. especially to prevent hyper and hypoglycemic events. If, they're eating at a certain time, it can, spike up their sugars, and then, things can just plummet from there. They should also check out the American Diabetic Association website. There's a lot of great information on there. So that's a resource to tell your patients, as well as, yourself as a nurse. You can utilize that to update yourself on current knowledge, help educate your patients from a reliable source. You can also use a meal plate app out there, so then patients can track their meals, see how many carbs they're eating, see how many sugars they're eating, things like that. Or you can consult a dietitian. That'd be a great one. Also incorporate individual needs, cultural, lifestyle, and socioeconomic status. So make sure you're asking those questions. Do you have any cultural preferences? Especially if someone has multiple diagnoses and this, diabetes isn't their only diagnosis. Maybe they're in end-stage renal failure and they have cancer. If they have all these things going on, they might want to keep their culture intact. So ask those questions. If they can't afford to get healthy meals, can we get Meals on Wheels for them? Can we get churches involved that donate food? What can we do for our patients here? Also including caregivers, family members, nutrition counseling, education, of those family members and caregivers. Especially include the one who cooks. So if the patient can't cook for themselves, or maybe they can cook for themselves, but their husband is the main cook in the house, include them in that education. So then whoever's cooking can help bring the best diet for that patient. You can tell your patient that they can use nutritive or non-nutritive sweeteners, but only in a moderation. So instead of using sugar in their coffee, they can, or in their tea, they can, use one of those non-nutritive sweeteners. We want to highly emphasize a diet low in saturated fats and trans fats, as well as mild alcohol consumption. Why? We talked about it earlier. Alcohol can cause complications. Also incorporating lean proteins and increased fiber. Exercise education. Exercise lowers the blood glucose level and encourages weight loss. It decreases insulin resistance and reduces cardiovascular disease. We recommend about 3 days per week of moderate activity for our patients. Patient may need to carry a quick carb snack in case of hypoglycemia, which we already spoke about. A good one, again, orange juice, Jolly Rancher, or glucose tablets. You can get those at Walgreens or any kind of convenience store. If the blood glucose is greater than 250 milligrams per deciliter and urine ketones are present, don't exercise until you go back to normal. That's what you should be teaching your patient. So the glucose-lowering effects of exercise can last up to 48 hours after activity. So that's another big education point that you can teach your patients, which will reduce complications. So if you have a patient that's confused and they exercise and they don't remember when they last exercised, maybe we can keep a log for them to prevent further complications. All right, insulin. So the most common regimens of insulin include short-acting or regular-acting. So they're going to do this before breakfast, lunch, and dinner. Or another one is a long or intermediate-acting insulin in the morning or bedtime. So again, rapid-acting should be administered 5 or 15 minutes before or during a meal. Short-acting should be administered within 20 to 30 minutes before meals. Intermediate acting is administered either daily, which is like in the morning or at night. So that's considered bi-daily. Or long acting, which is administered at the morning or bedtime. How to administer Ding, ding, ding. This is something that is so important to educate for your patients, as well as, to refresh, on ourselves. So again, we're going to start with washing our hands. We're going to gently rotate the insulin bottle, wipe off the tops of the insulin vials with the alcohol sponge or the wipe. Draw back the amount of air into the syringe that equals the total dose, and then inject the air into the vial. Remove the syringe from the vial, and then we're going to inject into the regular vial, right? So we're going to go cloudy to clear, cloudy to clear. It's very important. So after we inject the air into the regular dose, into the regular vial, we're going to invert the insulin bottle and withdraw the regular insulin dose. And then without adding any air into the NPH vial, we're going to carefully withdraw the dose and add to the regular insulin into the regular add to the regular insulin that's already in the syringe. So again, number one thing is that you want to do cloudy to clear. Cloudy is NPH and clear is regular insulin. Where can we administer? This is a great tip to know, especially when educating your patients. A lot of us, through nursing school, we learn to give it in the subcutaneous areas of the body, which mainly is the stomach, but there are some other places that we can give it. So behind the arm, in the buttocks, on the thighs, anywhere where we can grab a chunk and kind of stick, right? So that's going into the subcutaneous layer. So there's going to be fat in that layer, right? So it's not like an IM. We don't want it in the muscle. We want it in that subcutaneous layer. Something else we might see out in the field as a home health nurse is insulin pumps. Insulin pumps are usually battery powered that give subcutaneous continuous injections of insulin. They allow for tight blood glucose control, and they're programmed after meals to deliver a bolus infusion of rapid acting insulin based on carb intake. An infusion can be temporarily increased or decreased depending on carb intake, exercise, or illness, and insertion site should be changed every 2 to 3 days. Again, impaired healing here, so we're going to want to rotate the sites. It's another great education piece for your patients. One more thing, if a patient's on an insulin pump, they must check their blood glucose at least 4 times a day. Some of the complications of insulin pumps include accidental pump failure, obstruction of tubing, or obstruction of the needle, or an infection. Some of the complications of diabetes mellitus include stroke, hypertension, dermopathy, atherosclerosis, neuropathy, coronary artery disease, and a number of other ones. The number one that I want to talk about today is not only neuropathy, but I want to talk about impaired healing. I've kind of touched on it a little bit, but we want to really educate our patients that keeping their blood glucose in check is so vital and so important. Why? Because they have impaired healing. So, they're more at risk for injuries, and if they nick their foot over time, if they don't have their glucose in control and they're not taking their insulin as prescribed, we can have a lot of horrible wounds happening on, anywhere in the body, just because they already have a risk for impaired healing. So if their sugars and their insulin is out of whack, then they're not going to heal right. So really educating, don't wear tight shoes on your feet. If you get prescribed a boot to cover up your wound and protect that, make sure you're wearing that. You might have some neuropathy, which means you can't feel. So educate, make sure you're checking your feet. You're wearing, good hardy shoes, nothing that If the patient stepped on, a nail with a crock on, wearing a crock shoe or a sandal, it's not going to protect them. So, sturdier shoes like leather-soled shoes are probably going to help them better. But we know a lot of our patients have swelling in their feet, so we're going to want to make sure that the shoe is not too tight and that they're comfortable wearing it. So there's just some other education pieces that I just wanted to hit on. In terms of complications, just make sure you're looking out for these things in the field and you're educating your patients of the complications that could happen. So some of the key topics that we talked about today include an overview of diabetes mellitus, including the prevalence, the difference between type 1 and type 2, what is hypoglycemia, what is hyperglycemia, what are the signs and symptoms, the causes, and what should we do as a home health nurse. Additionally, we talked about the importance of nutrition and exercise, and we also talked about the treatment and education of glucose monitoring, insulin administration, and diabetes mellitus complications. Bet you didn't see this coming. I have questions for you guys, so pause this video and answer them at your discretion. Okay, so what did you guys get? So for number 1, which type of diabetes mellitus is a progressive condition? Type 1, type 2, prediabetes or gestational diabetes? Do you know the answer? Well, I got B. Type 2 diabetes mellitus is a progressive condition. It is not autoimmune or genetic like type 1. And gestational diabetes, that is when you are pregnant and you have diabetes. So it's not those. And it's not prediabetes. So when you narrow it down, you get B. Number 2, when educating a patient about diet and exercise with diabetes mellitus, which statement ensures the patient ensures the teaching? It's about to be Thanksgiving, so I did throw in a silly one. It's not A. It's not B. And it's not C. So it is D. If I incorporate proteins, fiber, and exercise into my diet, I will be able to better manage my condition. And here are some of my references. Thank you all for watching.